history and how to take a health history on this patient, you need to make sure that you're getting the health history of the family as well as the patient. Remember that there is some genetic background with a COPD patient. Also, the physical exam is so important to this patient, and looking at the overall history of the patient's respiratory condition, history of asthma, and all of those components. Illnesses they've had over the years makes a big difference as well. Nursing diagnoses, I'm going to go through these individually. So ineffective breathing pattern. If you think about this patient, they are not able to get a good gas exchange. They're tripoding in order to get a better air exchange. They are using their accessory muscles in order to get a better air exchange. All of these things are happening because their breathing pattern is ineffective. Ineffective airway clearance. Remember those thick mucousy secretions. Activity intolerance, we just talked about that, and building up their tolerance for activities. Imbalanced nutrition, less than body requirements. So as we look at this patient with the imbalanced nutrition, we want to think about getting them hooked up with the dietitian, both while in the hospital and as maybe a short-term evaluation after hospitalization to follow up. Compromised family coping. This is a disease process that affects the whole family. The family, if there are smokers, they're not going to be able to smoke near this patient. This patient's likely to have oxygen in the home, if not now, then in the future. And there cannot be any smoking in that home while there's oxygen in use. It's a fire hazard. There is the fact that the family is going to have a change in dynamics. If this person is the one who generally handles the cleaning and the cooking and all of the things that happen within the family, they're going to begin to need help because they are not going to have the ability to continue to handle all of those things. Their ability will be decreasing through time. Their energy level will decrease through time. And the family is going to have to adapt to that. Also, as the family goes out for events and goes to the park and those kinds of things, the patient is going to feel less and less like doing that. The patient's going to feel like they hold people back because they've got to tote along oxygen or because they have to sit frequently and they can't tolerate certain temperatures and all of that. And so they'll start to say, you go ahead, you go without me, and the family will feel guilty. And there's a lot of family coping and family dynamics that go into that need to be addressed. And then the decisional conflicts about smoking. Should the patient quit smoking? If the patient comes in and they're at end stage and they've been smoking the whole way through their disease process, is it worth trying to beat them over the head to quit smoking at that point? Probably not. Probably it's going to do more damage if they are at their last months of living to try to get them to quit smoking than to just leave them alone. It's not a decision for us to make, but the patient is the one to make that decision. And if they decide that's how they want to live out their final days, then we need to respect that. We also need to really make sure that we are clear on the safety issue if there is going to be oxygen. Tolerate activity levels, allowing for activities of daily, Our plan then, as we move forward through the nursing process, is that the patient will be able to adapt their breathing patterns to meet their demands sufficiently. They'll be able to experience an ease of respiration, maintain a patent airway, maintain their oxygen saturation levels above 90%. Now, this is for someone early on with COPD. So your patient who comes in and is more end stage, even with oxygen on, they're not going to maintain a level above 90%. If you can get them at 88, you're doing well with a lot of your end stage patients. Even that you're not going to see with some of them. Tolerate activity levels, allowing for activities of daily living. So these are goals that you might have for the patient, as well as a whole slew of other goals. Implementation, how are you going to reach those goals? So what you're doing here is working through a care plan, if you think of it. Your ineffective airway clearance, if you're looking at how to fix that ineffective airway clearance, you're going to assess their respiratory status and monitor their ABGs. You're going to check their daily weights, their intake and output, their hydration status, and then you're going to encourage fluids. Why are you encouraging fluids? Because that loosens up the secretions, and the looser the secretions are, the easier they are to cough out. Position them for comfort, for expansion of the airway. Assist with coughing and deep breathing at least every 2 hours. Provide tissues and a sputum cup, and position their trash can so that they can reach it, so they're not throwing tissues all over the place. Refer to the respiratory therapist. Administer an expectorant and bronchodilators as ordered. Provide supplemental oxygen as ordered. So if we look here at this one nursing diagnosis, ineffective airway clearance, and we think about this patient, what I always tell my students in my clinical area, and you'll get sick of hearing me say it, is when you're developing your nursing interventions, the things that you need to come up with for your interventions are things that will actually bring them to the goal. So if your nursing diagnosis is ineffective airway clearance, then your goal is the patient will have an effective airway clearance. So how are you going to bring them to that goal? Well, these things here are all that are listed are all great interventions. However, not so many of them are active. First, you want to think of active things that you can do to bring your patient to that point. So some of those that are here are encouraging the fluid, assist with cough and deep breathe, administering the expectorants and bronchodilators, sit the patient up for better air expansion and better ability to expectorate those secretions. All of those things are active interventions that will actually bring them to the goal. So what I would say to you if you're in my clinical group is you can assess them all day long. You can weigh them, take their eyes and nose, listen to their lungs, all of that all day long, and you will never make a change in your patient. You have to actually do something for it to be an intervention. So as you develop your care plans, try to remember that and make most of your care plan interventions actual active interventions. Off that soapbox now and moving on to ineffective breathing pattern. You see here listed for you some interventions for that. I'm not going to read out the interventions for each one, but just think, ineffective breathing pattern, what do you want to see? The patient will experience an effective breathing pattern. And what, as you develop that out even further into a outcome criteria, what are the outcome criteria that you would see in someone who has an effective breathing pattern? You would see that their respirations have decreased from 28 to 18. You would see that the patient is having decreased rales and bronchi. You would see that the patient is having decreased work of breathing, those kinds of things. You might see that the patient has less cyanosis. The next one, activity intolerance. As you look at activity intolerance, what do you want to see? You want to see that your patient will have an increased tolerance of activity. So how are you going to bring that about? Okay, and that's what you would think about with your interventions. Then the next one is imbalanced nutrition, and we talked about that some, and getting the dietitian involved in that. Compromised family coping. Your goal here would be simply that the family would develop improved coping skills, and you could list out some of the coping skills that they have developed. That's the same. Decisional conflict, smoking. So here again we have assess the patient's knowledge and understanding of their choices and make sure that they're fully educated on the choices and the results of their decision. Again, if the patient has 6 weeks to live, are we going to really improve their health by having them quit their cigarette smoking? That's going to increase anxiety levels. It's not going to improve their overall life status more than likely. So that's something that the physician can speak with them about, and you can make sure that they understand what their choices are. But we do need to make sure that they understand that they do have a choice, and we need to respect that choice once it's made. I think it's easier to accept when it's the patient who says, you know what, there's no use in me trying to quit at this point. I waited too long. That's easier than if someone else in the family smokes and they are not willing to quit, even though the patient's status is particularly bad and the smoke really bothers the patient. That is harder to accept often. Next, we move on to the evaluation, and that's the last phase of the nursing process. So, has our treatment been successful? Is the patient ready to be discharged? Is the patient consistently maintaining a saturation of greater than whatever your goal was? And is that on oxygen? And if so, then do we need to get them home O2? Patient demonstrates appropriate modifications of ADLs as required based on the ability of the patient to meet their daily activity goals and what they need to be able to do. If they're living alone, do they need to be living alone? Do they need to be moved into a different type of home situation where they have help? Or do they need a caregiver to come into the home for a certain amount of hours a day to help them to get up and going in the morning? Sometimes that can extend a person's time that they can stay at home by themselves for quite a time. Is the patient able to maintain a patent airway to allow for sufficient oxygenation? And is the family able to describe resources that are available not only for improved living for the patient, but to assist them with the caregiver role and with the family coping problems? Okay, that ends this long COPD slide presentation, and I thank you for listening.